So as we look at nitrates, let's review properly the nitric oxide pathway. Can you remember some drugs that work through the nitric oxide pathway? Are you thinking drugs such as hydralazine, the antihypertensive, and the famous nitroprusside and its cyanide toxicity for hypertensive emergencies? If you are, then you're just going to add yet a third drug that would work through cyclic GMP. And once again, nitrates are prodrugs. You see, the prototypical drug is nitroglycerin. And if you see nitro, you imagine well how it's a prodrug of nitric oxide. Key point about these drugs, their metabolism in specific vascular tissue. Nitroglycerin is primarily metabolized in the smooth muscle cell of large veins. And if it's metabolized in the smooth muscle cell of large vein, this is where the relaxing effect will be seen. Where does nitric oxide normally come from? Nitric oxide is normally produced, if you want, biochemically or physiologically, by the endothelial cells of the vasculature. It is actually produced by the breakdown of the amino acid arginine. Remember, it is essential during periods of growth, so an important amino acid at this. And the breaking down is achieved thanks to the enzyme nitric oxide synthase. Nitric oxide synthase, in turn, is stimulated by GQ-coupled receptors which are found on the endothelium. Examples of such receptors involve all inflammatory mediators, those same mediators that the immunologists, the pathologists, remind us as being responsible for the massive vasodilation of inflammatory responses. Chemicals such as bradykinin, chemicals such as serotonin, such as histamine, through H1 receptors, such as prostaglandins, certain leukotrienes. So really, those chemical mediators of inflammation. For us in pharmacology, we did mention an endothelial receptor to acetylcholine that was a muscarinic M3 receptor. This was a receptor that was found at the surface of endothelial cell and was GQ coupled. Recall that it was not innervated, but resulted in dilation of vessels only if it was stimulated by direct-acting agonists. Well, now we know that NO would be produced in the endothelium, then diffuse as a gas into the smooth muscle cell and stimulate guanylyl cyclase in order to increase the levels of cyclic GMP. Nitroglycerin, simply as a prodrug, will eventually be catabolized to NO. In the process of this catabolism, it does require cysteine, and this cysteine here actually comes as glutathione or GSH. SH in GSH, of course, represents those critical reactive amino acids. We'll think more about GSH when we're using those drugs chronically. In your text, nitrates are prodrugs of NO that venodilate. What does it mean to venodilate? Veins are large capacitance vessels. And as large capacitance vessels, when you dilate, you will pull the blood in the veins, decreasing the preload. That decrease in preload is a decrease in cardiac work. A decrease in cardiac work will result in decreased oxygen requirement. Notice with this mechanism of action, which are at therapeutic doses of nitrates, nowhere are we mentioning a vasodilatory effect of nitrates on the arteries. That is because this would arrive at much higher concentration, and higher concentration might be more likely to cause a hypotensive episode, and with hypotension, reflex tachycardias would become detrimental to patients with angina. Nitrates have been shown clinically for several years as decreasing the size of an infarct and improving survival of your patients post-MI. So nitrates are found literally in various settings. Nitroglycerin can be used at home as a drug administered sublingually because of extensive first-pass metabolism. And sublingually, it has been shown to actually decrease the occurrence of an MI, curtail an angina. Transdermal patches can also be used for more chronic administration and continuous administration of nitrates. Within our hospitals, as part of our acute chest syndrome protocols, IV formulation of the drugs are available, and it is with the IV nitroglycerin that we can see decrease in infarct size and post-MI mortality. Isosorbide is a formulation of a nitrate that is for extended and slow release of that nitrate, so for chronic usage. Nitroglycerin is more likely used when needed, when there is an anginal attack. Nitrates do come with side effects, potentially because of the venodilation itself, some classic headache, but far more worrisome the issue of the possibility of orthostatic hypotension. We really recommend that when patients will take nitrates, until they're used to their effect, they should be sitting down at the very least in order to avoid feeling dizzy and, with the actual increased sympathetic activity, suffer reflex tachycardias, fluid retention that would be detrimental to their cardiovascular condition. Other points about nitroglycerin often tested, the issue of tachyphylaxis. Now, this is a big word just to literally talk about acute tolerance. And as acute tolerance goes, let's understand that tolerance is simply referring to a loss of efficacy of a drug as you take more and more of this drug. We do expect tolerance with just about anything, but we normally expect tolerance to settle in after potentially weeks, if not months, of generally heavy use. Here, when we call it tachyphylaxis and acute, we're talking within 24 hours. And we're not talking overdosing on nitrates, we're talking potentially with something as simple as the transdermal patch. As a matter of fact, people who use that transdermal patch are told to remove the patch, particularly at nighttime, so as not to suffer the tachyphylaxis. Where might it be coming from? You remember in this diagram when cysteine was required for the activation and cysteine came as GSH? Well, GSH is in finite stores, and these finite stores would be depleted if I was constantly using the GSH for activation of nitroglycerin. This is why we recommend that nitroglycerin would be used primarily acutely and not chronically. Chronic use is associated with acute tolerance. Another possibility of relevance, the cardiovascular toxicity with the drug sildenafil. Sildenafil, you can follow in the margin of your syllabus, is a drug used primarily for erectile dysfunction. It is a phosphodiesterase type 5 inhibitor, and as such increases cyclic GMP to cause vasodilation, particularly in the vasculature of the penis, to result in erections. People with erectile dysfunction could very well be diabetics, people with hypertension, with cardiovascular diseases, with atheroma plaque, since in all these conditions there might be decreased blood supply. So they're good candidates for taking sildenafil. They're also the same patients who are taking nitrates, which also increases cyclic GMP, although through a different mechanism. Using sildenafil and nitrates would cause additive increase in cyclic GMP, and with it a massive drop in blood pressure. That drop in blood pressure resulting in reflex tachycardia and the potential triggering of a myocardial infarction.